All right, folks. Got a fairly short lecture for this topic on alternatives to morphine and some other drugs of abuse that are narcotic pain relievers. A lot of these are going to be drugs that you're familiar with. Certainly, you probably know people who have taken them for pain and for other reasons. They are commonly abused drugs. As we talked about last time, they do have some significant side effects that really do make them dangerous in overdoses and in combinations with other drugs. But I want to talk first about some pure opioid agonists. A number of those. Then we're going to talk briefly about partial opioid agonists and pure opioid antagonists, and then talk about the pharmacotherapy of opioid dependence. The first pure agonist we'll talk about is codeine. It's one of the most commonly prescribed pain relievers and also cough medications. It's usually combined with aspirin or acetaminophen for the relief of mild to moderate pain. Has a high degree of dependency. About 40% of people who use codeine do so for its dependency and not for its pain relief. Codeine is metabolized into morphine by one of the cytochrome P450 enzymes, specifically 2D6. Most of the clinical effects are due to the metabolism into morphine. There are 4 selective serotonin reuptake inhibitors that block metabolism of codeine into morphine. So if you or someone you know takes one of those, your doctor is going to need something other than codeine to prescribe for pain, and it's important that you let your doctor know that. Not all doctors are aware of this particular phenomenon, so keep that in mind. I'm not going to ask you which ones those are in the exam, but just do know, because you will need to know that there are SSRIs that will block that metabolism. So do know that. I don't need you to know the specific ones, though. So that's codeine. Again, probably a number of you are familiar with it. We talked last time about the abuse of codeine in purple drank, or Subutex, as it's sometimes called. And so it certainly is a highly abused drug. The opioid most commonly associated with abuse is heroin. Heroin is diacetylmorphine. It's 3 times more potent than morphine. It has to be manufactured out of opium products. That manufacturing can go awry. There are some cases in the past of single use of heroin associated with rapid onset Parkinson's disease, again, because of manufacturing defects. These aren't being manufactured by pharmaceutical companies. They're being manufactured by drug dealers. So it's important to understand that purity is an issue. Importantly, the reason why heroin has such a great deal of abuse potential is because of its increased lipid solubility, and it results in a rapid crossing of the blood-brain barrier, which results in a very quick rush or high, which is far more immediate and much more potent than morphine. It's completely illegal in the United States. It is legal in some other countries for use as a pain reliever. Oftentimes heroin is mixed with cocaine, what is called speedball. Either they are smoked together or injected together or snorted together, all of the above. The effects kind of offset one another, so people are very high but not as anxious as they would be with cocaine, but not as sleepy as they would be with heroin. It really creates a multi-drug addiction that is very difficult to treat. So again, a very dangerous combination of drugs. Hydromorphone and oxymorphone, we'll talk about them basically together. They're very similar. Hydromorphone, which is Dilaudid, is a structurally related to morphine. It's 6 times as potent as morphine. There are longer acting versions of these drugs available for treating chronic pain in those who have been sensitized to opiates. Not a lot of people using Dilaudid these days. A few people, even clinically, it's just not used that often. It's basically a synthetic version of heroin, and Not used all that often. It is on occasion. Mepiridine, which is also known as Demerol, also very addictive. Again, generally used clinically, not abused a lot. It's generally used as an intramuscular preparation for use in clinics, and again, oftentimes for preoperative pain. I will tell you this, having had it before, it is very painful, so I can see why it's probably not abused very often. But it is sometimes used intramuscularly for pain. Methadone is another pure opioid agonist. It's a synthetic mu agonist. Covers and blocks the effects of heroin withdrawal. And in fact, that's usually what it's used for, is as an adjunctive therapy to get people off heroin and onto methadone, and then hopefully eventually completely off of drugs. It's effective in treating chronic pain, about 1/10 as potent as morphine, so it has less likelihood to have abuse in the first place because it's not as potent. About 1/3 of heroin addicts experience withdrawal when treated with methadone. These are what are called non-holders, so those folks have to be treated in another way. But it can be effective in treating heroin addiction, but it is very controversial. Our next drug is oxycodone, which is also known as OxyContin, in combination with acetaminophen. It's Percodan. This is a semisynthetic opioid similar to morphine. This drug is one of severe abuse. And in fact, most drug overdoses and most drug deaths are due to this particular drug. This year, the greatest cause of accidental death in drug users is through prescription pain medicine. It's no longer heroin and cocaine or amphetamines. It's prescription painkillers. These are highly abused drugs. OxyContin is particularly powerful, and it was originally intended as a slow-release pain reliever for treatment of chronic pain. However, being clever as drug abusers are, people will usually crush and then either snort or dilute and then inject these pills to short-circuit the time-release mechanism. So rather than getting a slow, steady, small dose, they are able to short-circuit that process and get a high dose, and that's why they get high off of it. Oftentimes they will transition from abusing OxyContin to heroin. In fact, OxyContin is known as hillbilly heroin. There is a huge problem with pain clinics that are set up simply for people to get OxyContin prescriptions. It's a very, very intractable problem because we have to have some way to treat pain, but we do have to be very careful with that. Hydrocodone, again, another commonly abused pain. It's a common synthetic codeine used to treat mild to moderate pain. It's metabolized into hydromorphone, again, by those cytochrome P enzymes. It's usually combined with acetaminophen, which is the Lortab or Vicodin. Again, commonly abused. The commercial forms are Lortab and Vicodin and Percocet. One of the biggest problems with this is they're usually less than 1% hydrocodone, and the rest are usually acetaminophen. And because of the acetaminophen, there is a high degree of hepatotoxicity in abusers. In fact, a lot of times the treatment is for liver damage, or the biggest problem with these drugs is for liver damage from all the acetaminophen. Again, very useful for treating pain. Definitely, if you have an injury and are in pain, these are drugs that are worth taking. They're good for that, but you do have to just keep in mind that in certainly some individuals there is the potential for abuse. Our final pure opioid agonist is fentanyl and its derivatives. Fentanyl is an incredibly powerful narcotic. It's available as an injectable, transdermal patch, lollipop, or dissolvable tablet. It's water soluble, it's not lipid soluble, so it's usually given in one of these ways. The lollipops are for kids for preoperative pain. Transdermal patches for chronic pain use. It's oftentimes used in conjunction with other drugs and anesthesia. You do get long-term pain relief from this drug. It's a potent narcotic with high risk of respiratory failure and dependence. It's often used in conjunction with midazolam, the drug we talked about, as causing amnesia for conscious sedation procedures. It's a very effective combination eliminating pain and making people comfortable. So that's fentanyl, often again used very often. Subutex is another partial opioid agonist. Has a fairly low ceiling of analgesic effects, so it's not very powerful. Common side effects are flu-like symptoms. It's a possible medication for treating heroin addiction. Tramadol is another partial opioid agonist. It has a dual analgesic action. It is both an opioid and a norepinephrine and serotonin reuptake inhibitor. Importantly, there is a risk of serotonin syndrome if taken in conjunction with an SSRI, so you want to be careful there. There is only one mixed agonist-antagonist we're going to talk about, which is Suboxone. I'm not going to talk any further about it. We'll talk about it here in a moment when we talk about the pharmacotherapy of opioid dependence. But let's talk quickly about the antagonists. There are 3 of these that are clinically available. All have an affinity for the opioid receptors, but they bind to the receptors without action, so they block opioid receptors. Previously, we talked about flumazenil and its ability to block benzodiazepines. This is the same thing with these drugs. Narcan is an injectable, which is used to treat opioid intoxication and precipitates withdrawal. Will keep people from getting high at all if you have them on Narcan. Naltrexone is an orally absorbed antagonist, which is used for chronic therapy to prevent opioid relapse. People are taking this pill and they end up abusing a drug. They're not going to get high off of it because this will be blocking the receptor. And nalmefene, which is an injectable, is used to treat narcotic overdose, in particular narcotic overdose induced respiratory failure. Finally, I want to talk briefly about the pharmacotherapy of opioid dependence. We'll talk more about treating drug disorders later, but opioid dependence, keep in mind, is a brain-related medical disorder. Long-term abstinence is, of course, the goal, but it's very difficult to achieve, particularly with heroin addicts. The most interesting data and the most supported data support a prolonged agonist-antagonist maintenance with a drug like Suboxone or Embeda. And that's all I need you to know about those drugs, is they're used in order to keep people off of these drugs. So someone who has developed a dependence to heroin, hydrocodone, or OxyContin oftentimes will be treated with Suboxone. Okay, well that is our discussion of narcotic pain relievers. We've started to transition now from drugs to treat disease and distress and into drugs of use and abuse, in particular recreational drugs. We'll start with the legal drugs, caffeine, nicotine, and then talk more about other drugs which are not legal. So we're turning to that next, which I think most of you will find very interesting.